Assalamualaikum and a very good morning to the family. Thank you for taking some time off to attend this health webinar series this morning. I am Dr. Hana Shafinas Jamaluddin, one of the Haematopathologist from the Department of Pathology. We'll be hosting this morning's session. Our presentation this morning is on morphology in hematology. So we hope to share some light on some of our experiences, as well as a few interesting cases in which we think would be beneficial and also informative for those who might be wondering the kind of diagnostic work we do in the lab. To share these experiences and cases will be my fellow colleague, Dr. Poh Kim Yan, specialist in charge of the bone marrow and immunophenotyping in our laboratory medicine department. So without further delay, I will pass this session to Dr. Poh. Okay, Poh.
Thank you, Dr. Hana, for the kind introduction. And a very good morning to all the attendees on today's morning. So without further ado, I will share my PowerPoint. Okay, so the topic for today's CME is morphology in hematology. Is it a trick or treat? So before we start, this is a picture that I took from one of the peripheral blood film that we saw. Actually, this beautiful picture is actually a fungus or mole that looks so pretty under the microscope with all these undulating hairs coming out from the center. So today's CME will be a very fun and interesting CME where I will show you a lot of pictures and have a look under the world under the microscope. So CME today will cover a bit of introduction on morphology, and then we will have a few case series with regards to ALL, AML, and also lymphoma. At the end, we will have a bit of conclusion. So what is morphology? Morphology is a study of the structure without regards to their function. So morphology assessment can be divided into macroscopic, meaning examination by naked eye, as shown in this picture, figure 1. And then there's also microscopic examination of morphology with the aid of a microscope, as you see here. So in hematology, because we are assessing the morphology of mostly blood cells, which are very small, so a lot of time we spend a lot of time sitting in front of a microscope. But this is one of the examples when microscopic examination will give you some clue or hint in hematology. Is can you see on the right hand side this slide? The color looks a little bit different from the salmon pink that you usually get from smearing a peripheral blood. This is in the case of gammopathy or multiple myeloma. Before we go into the case series, let me just ask you all one question, and then you can interact with us in the chat box. So biological sex can be determined from peripheral blood film examination. Yes or no? So the answer to this question is yes. So the observation of this nuclear neutrophil drumstick projection that was described back in the 1950s correlated well with the biological sex of male and female. So if you can observe this drumstick appearance that is connected with one of these stalk of filament, it actually indicates a female individual. So a little bit on the history of this discovery. Actually, this projection or satellite from nucleus is later on given the name as Barr body because of the discovery made by Marie Barr back in the 1948. The story of this observation is interesting in the way that initially Barr and his colleague was doing some research on how electrical stress induced changes in the neural cell in cats. However, there are also incidental observation of this nuclear satellite, as you can see here in this figure 1. So they observed that this nuclear satellite, it correlate very well with the female cats. So they later on also extend this observation into the human's neural cells and also buccal mucosa and blood cells in the human, and the findings are consistent. This bar body was even used to determine the biological sex for the intersex or ambiguous genitalia back in the 1950s. But bear in mind, chromosomal analysis was not available, so this was the only resource they have. And the bar body is later on confirmed. It actually contains one inactivated X chromosome in the female. So if you are interested, you can look up for this journal. The bar publication is actually published in the 1949 in Nature's journal. And it's also very interesting if you want to look at the second journal for the story and history of this bar body. So this bar body is just to illustrate to you who would have known that by observing, careful observation of the morphology actually also can tell you so much story on sex chromosome. So now let's move on to our case series today. The first case will be on acute lymphoblastic leukemia, or short form is ALL. So these are the color atlas that I take from our textbook. So these two resemble your lymphoblasts. They can have a smaller morphology, and then they can also have larger morphology. And then if you can appreciate the chromatin pattern here is a little bit more open compared to this Burkitt lymphoma cell, which is more of a mature cell. You have a nucleus chromatin pattern that is more dense or blue. If you can see here, the chromatin is open, and then you also can see this prominent nuclei here. So this cell is actually a Burkitt lymphoma cell, which is a mature lymphoma cell with this characteristic of multiple vacuoles in the cytoplasmic, and also the color of cytoplasm is also a little bit more deep blue. So the case number 1 is a 15-year-old Indian boy with a short history of loss of weight, loss of appetite, fever for 2 weeks, and also noted to be pale. This is a case referred from GP, and then on examination, patient has an enlarged liver and spleen. So this is the peripheral blood that we saw. So can you see the most striking features in these blast cells or abnormal cells that we saw are actually multiple cytoplasmic vacuoles. I would say near to 20. And then this is the bone marrow examination of this patient, also shows similar findings. This blast I want to illustrate to you is a deeply basophilic or dark blue color cytoplasm. And then this one is the blast that you can see multiple vacuoles. So of course, the population of the blast cell or abnormal cells in this case is a bit heterogeneous, I would say. So you can see you have smaller blasts, you have larger blasts, and then you also have blasts with the vacuoles and the color of the cytoplasm that is very basophilic. So this kind of cells here actually might raise your suspicion, like, could this be a Burkitt lymphoma cell? And then for your information, the presentation of this patient is also quite aggressive or quite aggressive. However, when we do the flow cytometry, it turned out this actually is a blast cells. They are immature cells instead of they are the mature Burkitt lymphoma cells. So on flow cytometry, they fall in the blast window with CD45 dim, and then they also lack immature markers. They are actually positive for immature marker for TDT and CD10. The surface immunoglobulin is negative. CD20, which is the mature marker, however, is actually aberrantly expressed in this leukemia cell. So based on this flow cytometry, actually, it has proven that this population of cells are actually blast cells instead of the mature lymphoma or Burkitt cell. And then you might also wonder, like, why some of the cells looks a bit like Burkitt. So we actually did a MYC translocation also to really like exclude Burkitt lymphoma, as well as the very rare cases of BALL with just MYC translocation with something else, but can resemble, can give you the features like Burkitt, what we call Burkitt-like morphology. Cytogenetic of this patient is show hypolipoproteinemia with a molecular genetic result of TP53 mutation. So eventually this case is treated as a high-risk BALL, and then patient is currently 9 months post stem cell transplant and doing well. So now we use the example of acute promyelocytic leukemia, or M3, as the example for our myeloid cases. So this is the classical APML morphology that you will see. So the cells that are labeled as B are what we call faggot cells, where you can see all these abnormal promyelocytes with multiple rods in the cytoplasm. The cells that are labeled as A are also abnormal promyelocytes with bilobe nucleus, and you can see the cytoplasm is actually very granular. So interesting thing is in APML is you see the faggot cell is almost pathognomonic to, you almost can diagnose APML just from morphology if you see the faggot cell. So this is case number 2. He is a 13-year-old boy presented with intermittent fever for 2 weeks and hepatosplenomegaly. So this is the peripheral blood film for this boy. So what you can see here is the most prominent features in these cells are actually, they are all bilobes. You can see here, this is clearly a bilobe, and then here you can see the bilobe nucleus a bit overlapping here. However, you don't actually see any rods, and then you don't actually see the hypergranular cytoplasm as well in this case. But the morphology of this bilobe abnormal promyelocyte in the peripheral blood should raise the suspicion of still APML, but a hypogranular or microgranular variant. So this case should not be very difficult for a haematopathologist. We still see the hypogranular or microgranular variant APML quite often. So both of the hypergranular and microgranular variant of APML can cause the IVC, and this will be usually will be the associated cause for their early death before the discovery of ATRA and arsenic trioxide in treating APML. So before ATRA, APML has a very bad prognosis due to the complication of DIC. However, after the introduction of ATRA, APML patient has very good prognosis. So in this case, the immunophenotype also confirmed this is a case of APML with the classical CD34 negative, HRADR negative, 11B negative, 417 positive, 1333 positive. However, in this case, in the hypogranular variant, you are not surprised to see a small proportion of this blast or promyelocyte can have 34 expression and CD2 aberrancy. So sometimes the morphology of this hypogranular variant actually can predict the findings that you will get in your immunophenotype, as well as the isoform of or the types of PML-RARA translocation, in this case, is confirmed to have a short isoform together with a FIG3 mutation. So the progression of this patient is currently has achieved molecular remission from APML. So this is just a case to show you the APML does not really need a Fager cell to call it a APML. And with the morphology of this hypogranular, actually by this morphology, you can actually kind of predict the immunophenotype aberrancy and also the type of translocation 15, 17 or the PML-RARA isoform by their morphology as well. So we will continue with another case of M3. So this is a 55-year-old gentleman. We received this sample as an outsourced sample from one hospital from Hera, a different state, for flow cytometry. The clinical history provided in the form is query APML. The peripheral burden has been reported from the referring hospital. So we received this sample near to 5 p.m. on a Friday afternoon. I still remember this case. So because of the indication of APML, so my MLT and I have to stay back to release the report for this patient on a Friday afternoon. So all the complicated cases likes to come in a Friday afternoon. So it's the same for this case. So for your information, even though we are receiving the sample for flow cytometry, but we also will look at the morphology of the peripheral blood film ourselves, because I cannot stress enough that all the tests in hematology must be interpreted as a whole. So even though this is only requested for flow cytometry, but examination of the morphology and correlation with the morphology is very important. So I can get the confusion why they say it's a APML, because we do see some blasts that are actually a bit bilobe, like this one, if you can appreciate the nucleus. And then this is also another bilobe one, and then you can see the overlapping here. And then these cells, which is a little bit bigger, you might ask the question, like, is this a promyelocyte? They have a little bit of granules here, but not really all rods or faggot cells. But the bilobe blast, something like this, is really there. So when we do the immunophenotyping, they are similar, like the case that we saw in case number 2. So the immunophenotyping is almost similar like case number 2, which is a APML. So are you happy to call this a APML as well, based on the first clinical suspicion from the referring hospital, and also a flow that is actually fitting into their differential diagnosis? But wait, so when I saw the PBF, I also noticed, besides the biloblasts and those hypergranular abnormal cells, I also see something like this. If you can appreciate, there is a very big indentation here, like a giant prominent nucleoli here. And then some blasts also show this appearance of what we call a fish mouth appearance. Basically, this is just the prominent giant big nucleoli, but it's angled at this direction, then you see it like this. So the general picture is, for this patient, is the most striking feature is this blast with this very giant invagination of nucleoli, creating a cupping appearance. You can see some cells here got granules, might be a bit confusing. I agree. Some of these cells might be a bit confusing as well. So this is a case actually not APML. despite the fact of the first clinical suspicion from peripheral blood, firm reported from para, and despite the fact the immunophenotype actually is like APL. So AML with mutated NPM1 is AML with a gene mutation associated usually with myelomonocytic or monocytic features. The rare cases also exhibit prominent large nuclei creating this coupling appearance, and then they can have immunophenotype features like acute promyelocytic leukemia, which is your M3. So this case, I actually have to call the referring doctor, say, I think this might not be APML. This might actually be a AML with mutated NPM1. So later on, this case is confirmed to be having NPM1 mutation together with FIT3, and the translocation 1517, which is the diagnostic for APML, is actually negative. So in this case, what I want to illustrate to you is sometimes the morphology might trick you, but sometimes in this case, it's the morphology that actually saved me from committing to something that is not. So in this case, I would say the morphology is the one that actually saved me from actually committing to APML, which will be the wrong diagnosis, because the treatment for APML and other AML will be different. So this diagnosis actually will carry clinical consequences. Next, we will move on to use hairy cell leukemia as an example for a case of lymphoma. So as the name suggests, the hairy cell leukemia, which is one type of mature B-cell lymphoma, will have this characteristic hair-like projection circumferential to the cytoplasm. So case number 4 is a 64-year-old gentleman. He was admitted with a COVID positive pneumonia category 5, required intubation and ICU admission. He is noted to have marked leukocytosis to hyperleukocytosis, the total wide range from 50 to 150. Further history, patient was told to have a Curie leukemia lymphoma 5 years ago in a private hospital, but never investigated due to financial constraint. So this is what we see from the peripheral blood. To be honest, I think these cells looks exactly like the one that I show you here. But the final diagnosis for this patient is actually a hairy cell leukemia variant. But I want to bring your attention to hairy cell leukemia variant, even though the name has a hairy cell leukemia, but they are actually two different diseases that are not biologically related. It's a bit different from APML microgranular variant, where the treatment, biological, and then the translocation 1517 is actually almost similar. But hairy cell leukemia variant is not related to hairy cell leukemia because, and also the treatment for hairy cell leukemia also different from hairy cell leukemia. The things that suggest us to think of this variant is because of hyperleukocytosis and the absence of monocytopenia in this case. So the flow cytometry shows a clonal B cells, and then these 4 markers are what we will use for hairy cell leukemia. If you have more than 3, it's the classical hairy cell, but in this case, only 2 are positive. We later on did a BRAF V600 mutation also, which this one will be positive in virtually all the hairy cell leukemia, and they are not detected. So putting everything together, this patient is diagnosed as hairy cell leukemia variant. However, patient passed away on the 2nd day of admission. So this case is to illustrate to you, they might look exactly the same, but actually they are totally different disease. Case number 5 is a bonus case that I saw. So we received this cerebrospinal fluid and for cytospin for a 7-year-old boy with a T precursor ALL, and then he's 1 week on induction chemo. So to our surprise, we saw something like this that looks like a worm to me. And then it is really a organism or nematode because you still can see the gastrointestinal tract here in the center. And then I'll put a picture of this. If you can appreciate, this is the details of the intestine actually looks the same. So this slide is actually reviewed with a parasitology from our colleague. And then we do agree that this nematode looks like Strongyloides tocoralis. And then in view, this is a patient that are immunocompromised and then having neutropenic sepsis. We suggested the clinician to send for stool for ova and cyst, as well as serology for strongyloides. But both of these are actually turned out to be negative. We also try to repeat another stain from the remaining CSF sample, but we could not see these worms again. Patient is actually empirically treated with albendazole while waiting for this test result to come back, but they are all negative. So I think in retrospect, our impression will be, could this worm actually a contamination from the tap water that we used to wash and stain our slide? So the conclusion for this presentation will be, is seeing believing? I doubt so. Even though a lot of time they are actually true, but don't get treated. So I still believe that morphology is a very valuable tool in diagnostic pathology. It is very fast, easy, readily available even in a district hospital, but we must know the limitation of morphology because the structure does not equal to the function. And then as a pathologist, we need to be aware of the variant and unusual morphology overlapping. And in difficult cases, we need to resort to the supporting and supplementary tests, be it routine or more specialized tests like flow, molecular, and cytogenetic. Last but not least, I think clinical pathological correlation is the utmost important, and morphology and all the other tests in pathology should be interpreted as a whole with all the other supporting tests. And before I end my session, I just want to allow me to end with this sharing with Chinese idiom. So this is the literal translation, and then I'll explain a little bit what's the meaning behind it. So a mountain is seen as a mountain. A mountain is seen not a mountain being. A mountain seen remains a mountain being. So basically, this refers to the 3 stages of life or wisdom. So when you are inexperienced and naive, you will believe what you see. So if people tell you anything with this shape and this size is a mountain, then believe it. But as you grow more experience and then you grow older and gain more wisdom, you have seen different mountain with different size and shape, and you also have seen something that is actually not a mountain but can resemble like a mountain. You start to think critically, and then you start to have more doubts before you want to commit to something. So the last stage, I hope everyone can achieve is you will verify and have your doubt and you have your train of thought before you want to accept or reject what you see. With that, I thank you for your attention.
Thank you, Dr. Poh, for the very excellent and informative presentation. We do have a few more minutes. If anyone have any doubts or any questions to ask the presenter, you may do so on the Q&A box, and I'll try to read up. While waiting for any questions, echoing what Dr. Poh was saying, we in pathology, although with the advancement of medical technologies and the tests that's available, at the end of the day, we always refer ourselves as a morphologist, in which we care for what we see and take everything on the whole before giving out diagnosis. So we tend to use the eyes for quite a long time. So we call ourselves morphologists. We are haematopathologists incorporating all other tests that's available. Okay, there's one question coming up. Okay, I will read out. One of the questions is asking, for exam purposes, if it's APML, will there need to be aurochs on the cells that are seen?
I'm afraid you don't really need the aurochs to call it an APML. So because in hypogranular variant, you might not see granules, you might not see aurochs. So if you see a lot of abnormal promyelocytes that are actually bilobes, and then you still should put your differential down as a hypogranular or microgranular variant of APML.
There's another question, I think, pertaining to your last slides on the worms query contaminant. Are we suggesting that the hospital tap water has worms?
I'm not too sure, but strongyloides actually can be found in the tap water as well, and soil. So I'm not sure whether it's the contamination from the dirty hands or actually the contamination from the tap water also. But we only see this only once, so it's quite difficult for us to put too much of conclusion to where actually it came from. It can come from the soil or some dirty hands, or actually also from the water.
Because any findings we have, there must be a conclusion that comes out of it. So we can't just disregard any findings that we see. So at the end of the day, we will have to make some conclusion. So that's one of the possibilities. Okay, so there's no more questions. Once again, I would like to thank Dr. Poh for the very interesting presentation. I shall pass the session over to the second moderator, Madam Nur Zehan, for the next session. So thank you everyone for attending.
Thank you, everyone.
Thank you, Dr. Hana and Dr. Poh. So, Assalamualaikum and good morning to all participants at Breakfast at UM. Thank you because you still with us. My name is Zehan Ahmad. I'm from Department of Nursing Science. So I will be responsible for this moderator for this session. So I'm glad to welcome our next speaker, Prof. Maria Isabelita Rogado, who will be present on topic geographical disparities in sepsis outcome. So first, let me introduce her first. Prof. Maria Isabelita Rogado is a graduate of St. Juan de Dios College of Nursing. She has Master of Art in Nursing and Management Development Program. With over 30 years of nursing experience, Prof. Bell is known for her expertise in clinical nursing education, primarily in critical care, and also leadership development. She is the president of the Critical Care Nurses Association of the Philippines, and currently she is Vice President of World Federation Critical Care Nurses and Ambassador for South and Northeast Asia. All right, Prof. Bell. So for today, a topic on geographical disparities in sepsis outcome. As we know, sepsis is one of the most common cause of patient mortality, and there are recommended standardized treatment protocol to sepsis, and there exists a wide variability in clinical outcome due factor related to geographical disparity. So in Prof. Bell's presentation, her aim to provide evidence-based information on how sepsis outcome influenced by factor health disparities. So to all participants, you can ask questions in the chat box and also at the end of presentation. So Prof. Bell, the floor is yours.
Thank you very much, Madam Noor Sehan Ahmad, for that kind introduction. So let me just first share my screen. So thank you very much again, Madam Noor Sehan Ahmad. We will be discussing topic related to sepsis because we all understand that sepsis is the #1 cause of death in the hospital. It is also the number one cause of hospital readmissions and number one cause uh, of increased healthcare costs. Now, what is new about the surviving sepsis guideline in 2021 is that it gives emphasis now on improving the care of sepsis patients after they are discharged from the intensive care unit, and at the same time they give emphasis on representing the greater geographic and gender diversities from the previous version. So the focus of my 20 minutes discussion will highlight on geographic gender diversities. And also I would like to inform all participants that I will be sharing a recorded presentation to keep my presentation to time. So please bear with the recording. My presentation this morning is about the geographical disparities in sepsis outcome. It is important to take note of the factors that affect geographical inequality due to its direct impact to the outcomes of sepsis. I have nothing to disclose. Health disparities exist and can be attributed to different factors. These factors are intertwined and connected to each other. Therefore, it is important to understand clearly how each factors impact disparities in healthcare and health outcomes. During this session, we will focus the discussion on geographical disparities in relation to sepsis outcome. The study of geographic patterns of diseases is important because the information may represent associations with localized population and environmental characteristics. It can provide knowledge that can determine how health is influenced by geographic factors and provide important insight into what contributes to disease outcomes that can offer options for disease prevention. Investigating the mediating role of geographic characteristic in the risk of sepsis allows for possibility of intervening with health policy and implementation of needed healthcare resources, and that socioeconomic status remains an important determinant of health and mortality. Like many public health outcome measures, mortality and morbidity are critical indicators widely accepted for understanding the health stressors on a population and tracking health impacts of operation. Major challenges to implementing a randomized survey for health indicator exist, such as manually created clusters of geographic population units. This approach is time-intensive, requires significant ground-level mapping, risk selection bias, and introduces increased variance due to clustering effects depending on the health variable of interest. To measure the inequality or disparities between geographic areas, it is necessary to define what an appropriate geographic area is. A definition of geographic area as measures of analysis highly depends on the inequality to be evaluated, such as health resources, health expenditures, utilization of health services, and health outcomes. One of the main objectives of the national policy for publicly financed system is to provide equal access to health services. It is for this reason that existence of geographic differences has become documented by a lot of studies from various countries of the world. Observed variations in health resources reflect the variation in the real health needs of the regional population. The intent of the succeeding presentation is not to show a conclusive picture of disparities, but rather take a look on some of the studies that present samples of disparities as it relates to factors affecting geography and sepsis outcome. Geographic disparities are often described and studied where in relation to community and participants' characteristics, quality of care, and methods in the identification of sepsis events. Community characteristic in terms of population density, as shown in the study of Diamant et al., reported that there was a 15.3% increase in the absolute death from sepsis in Sao Paulo. This was concentrated in the most populous region, tending towards the center of the city. In terms of private and public hospital in the community of Argentina, the study of Estanzoro differentiated the hospital types by defining the patient and hospital characteristics. The patient characteristics were defined in terms of the differences in age, BMI, comorbidities, years of education, employment, and Apache score. The study found similarity in the self-rated overall health status, home to hospital distance, time to receiving the first dose of antibiotic and IV fluid bolus. The hospital characteristics were defined in terms of infection, a 28-day mortality, hospital mortality, antecedent visits to health clinics without patient admission, personal turnover, delay in diagnosis and receiving treatments. Similarities were found in terms of the length of mechanical ventilation, hospital days, as well as treatment and management of sepsis. Estenssoro et al. Posits that public hospitals were associated with higher mortality compared to admission to private institutions, and that admission to public hospitals can be considered a proxy of low socioeconomic status, given that they serve uninsured and socially disadvantaged groups. Atun et al. Claim that public hospitals are usually underfinanced by the national or local health ministries. In terms of access to health, the study of Richardson showed that there are differences in accessibility to healthcare, such as preventive health services, primary care, and behaviors that promote health. Minority populations have limited access to healthy food options, exercise facilities, health information, safe environments, and quality health care. Moore, on the other hand, reported that persons living in regions with otherwise higher access to care are still at greater odds for sepsis. Akinjimi Yu found that impoverishment may impact health through access to personal health care providers, quality of care, healthcare literacy, and availability of effective medical treatment. While Galliford posits that access to healthcare is a complex concept that involves multiple components, and the process of which person actually gains access will depend on financial, organizational, social, and cultural barriers that limit the utilization of resources. Moore et al. Characterized geographic difference in terms of classifying the community as sepsis belt or non-sepsis belt, and sepsis cluster or non-cluster. The participants' socioeconomic levels are defined in these differences. Likewise, Moore surmised that the communities with higher rates of poverty, an indicator of lower social economic status, are associated with the worst outcomes in sepsis. Mendu stated that among the critically ill patients, those living in communities with higher neighborhood poverty rates were at 49% increased risk of developing acute bloodstream infection. Estenssoro, on the other hand, posits that decreasing gross national income per capita is associated with rising mortality in ICU patients in general and also in patients with ARDS. The study of Welch et al. Showed that the differential outcomes related to socioeconomic status are not exclusive to low median income countries. In high-income countries like England, a higher deprivation index has been related to increased ICU mortality, and this was calculated after education, employment, income, disabilities, and other variables. On the other hand, Rush et al. Showed those with the lowest median income level were younger, less likely to be Caucasian, had lower health insurance coverage, and had higher mortality compared to residents of the highest income quartile. The study of Bien and Benares reported that in other high-income countries, a low social economic status has also been associated with more severe diseases upon ICU admission and higher comorbid conditions. The study of the Southeast Asia Infectious Disease Clinical Research Network on the causes and outcomes of sepsis reported the geographical disparities in the tropical region. The study showed that tropical infectious diseases were common causes of sepsis and severe sepsis in this region. Several studies examined causes of fever and bacteremia in the region. However, none applied the predefined wide array of diagnostic tests and assessed the relative distribution of pathogenic bacterial, parasitic, and viral agents identified in patients admitted with community-acquired sepsis. There were also emerging pathogens that were recognized as an important cause of sepsis and diarrheal illnesses in the region. The study emphasized the need for rapid, inexpensive, and accurate multi-disease diagnostic tests for tropical developing countries and strongly support the recommendation of surviving sepsis campaign to obtain blood cultures before administration of antibiotics within 3 hours for patients presenting with sepsis. In terms of patient characteristics as far as age is concerned, the study of Jamant showed that mortality rate was higher in regions where the Human Development Index was higher. This is due to pneumonia that develops into sepsis or sepsis-related infection, a condition that is more frequent in the elderly. As far as race is concerned, the study of Moore showed that Black participants were at lower risk in developing sepsis than the white participants. According to the study of O'Hell, the Black patients receive inferior care such as lower quality and intensity of care. However, in terms of genetic susceptibility, there is a growing body of literature discussing genetic determinants as a cause of increased susceptibility to infection and sepsis. However, in the age of genomic medicine, it appears that minority populations are among the last to benefit from its advances. Studies have also shown that in terms of comorbidity, chronic conditions such as diabetes, renal failure, COPD, obesity, and HIV have placed patients at the risk susceptibility to infection and sepsis. Poverty levels such as the lower socioeconomic status and minority groups were associated with lower rates of health insurance and decreased access to preventive health services. Likewise, Dimiglio also cited that health behaviors in relation to people who have no vaccination and those with weakened immune function as a result of their environment and those who adopt to unhealthy diets are at risk for increased sepsis incidence and are likely to present more complicated infection. In terms of quality of care, it was reported that inter-hospital differences play a significant role in racial disparities of sepsis management. It was also cited that patients from historically underserved population and impoverished environments are less likely to seek and obtain healthcare resources and have a lower level of trust in medical professionals. Likewise, it was cited that there seems to be bias or an unconscious association of the healthcare professionals' negative attitude to individuals based on irrelevant characteristics such as race or gender. The study of Ed Soro cited that health systems are usually fragmented, consisting of an overloaded public sector serving the poor, the social security agencies for the formal workers, and a private sector for the wealthy. These complex structures leads to further social segregation, given that the healthcare process perpetuates the differences in social economic status. Likewise, there seems to be a general lack of knowledge among physicians and healthcare personnel about sepsis that occurs worldwide. This situation might lead to delayed treatment and progression to more severe forms of disease like septic shock. In terms of intensity of care, studies have shown that among sepsis patients, Blacks were more likely to be hospitalized and require ICU level of care, and that they experience a longer length of stay. However, the conclusion of a more recent study have been inconsistent with the prior literature. A retrospective study by Bamato showed that administrative claims that that blocks had a significantly higher incidence of sepsis and were likely to receive ICU care but had similar adjusted case fatality compared to the whites. A similar study by Moore and colleague found that blacks have a lower incidence of sepsis and receive similar intensity of care compared to whites. With increasing hospitalization and decreasing case fatality rates, there is a growing number of severe sepsis survivors with complex medical needs. The study of DiMiglio posits that insurance status plays a more significant role in post-acute care utilization, and this has been supported by previous literature. In terms of methods of identification of sepsis events, previous studies have applied ICD-9 taxonomies of Martin and Angus in order to identify sepsis and severe sepsis hospitalization. A recent study concluded that ICD-9 discharge diagnoses have high specificity of 94.6% but with poor sensitivity of 27.6% for detecting community-acquired sepsis events. The fact that present on admission flags are not commonly available in discharge data sets used to research purposes, prior sepsis studies were also unable to disentangle early community-acquired sepsis from that of the latter hospital-acquired sepsis. Therefore, this approach could lead to documentation bias, and research suggests that the use of discharge diagnosis tends to have poor sensitivity to detect sepsis. Another documentation bias may be related to physicians who were more likely to record sepsis, infection, and organ dysfunction diagnosis based on the patient's race. Likewise, the use of varied detection and definition not encompassing laboratory measurement and documentation of infection attributable to hospital or emergency department practices may also lead to differing rates of sepsis. So in conclusion, we would like to say that geographical relatedness is a core component of epidemiological research and outcome investigation. The existence of geographic differences in the distribution of health resources is a reality in both developing and developed countries. Therefore, a continuous and stringent inequality measurement is an important methodological tool that will help researchers and policymakers in evaluating degree of inequality to support measures for better sepsis and health outcomes. Thank you very much for your kind attention. Before I finally end my presentation, I'd like to share with you some invitation pertaining to the World Sepsis Spotlight. Oops, can I just move? Okay. Okay, so I'd like to invite you to the World Sepsis Congress Spotlight, which on April 27, they will be presenting the theme on the novel therapeutic and diagnostic approaches to COVID-19 and sepsis. Now, this is a free online congress, and they will now spotlight on the newest therapeutic and diagnostic approaches for the COVID-19. It will cover all novel aspects of our understanding of bacterial and viral sepsis. So if you like more information, you can log in at wscspotlight.org and register for free. Another invitation that I would like to present at this point is for you to attend the International Congress this June. Now I am for the open forum.
Thank you very much, Prof. Bell, for your nice presentation. Okay, so we open for question. There is one question, Prof, from Dr. Yu. So therefore, we should push for requesting care provider with the physiological cause of death too, in addition to the ICD cause of death. What are your thoughts on this?
Okay, so of course, it is very important that we define the cause of death. And primarily in the ICD, you would see that sepsis is not well defined yet because under the ICD, most commonly they would look at the primary cause of the disease or illness, like let's say cardiac arrest or cardiovascular or stroke, but they will not, in the course of the hospitalization, they can go into sepsis and eventually end up septic shock. However, because of these consequences and not well defined the diagnostic parameters for the cause of death, they often take most of the physician will often take on the primary cause of admission. So yes, I agree with you that we should push more for the physiological definition of sepsis as a cause of death in trying to identify the ICD-9 or the cause of death that is related to sepsis. So that's why we cannot see in the mortality, morbidity, that sepsis pertains to the number one cause of death, and it's usually cardiovascular that is predominantly described. But they're silent about really the sepsis event that happens during these particular illnesses. I hope I answered your question.
Yes, hope that will answer you, Dr. Yu. Maybe, Prof. Bell, what is your recommendation for Asian country for this issue?
Okay, for our Asian country, we have to be more specific in defining through data or laboratory diagnosis the event of sepsis. And that when we have to conclude in our death certificate that the cause of death is sepsis, then we have a foolproof data supporting why we have identified the cause of death as sepsis. Now, this can be an internal hospital based or it can be a institutional based wherein we can probably raise the issue, and that's why there is this global campaign for Sepsis Alliance and the Surviving Sepsis, wherein we can all join in. I invite you to log in the Global Sepsis Alliance and join as proponent and advocate for surviving sepsis. So this is one call of the Global Sepsis Alliance to really integrate the knowledge about sepsis, and that we will be able to pursue this particular identification and really help combat this particular cause of death among our patients.
Okay, thank you, Prof. Bell. So there is no other question. Maybe you want to add anything before we end the session, Prof?
Yeah, so again, let me just for additional information about sepsis. You can get a lot of infographics from the Surviving Sepsis campaign, including the Global Sepsis Alliance website. They have a lot of infographics and a lot of latest articles and care management pertaining to COVID and sepsis, because right now there is a 3 organization support for identifying that the end result of COVID for mortality is really sepsis because of the multi-system involvement of patients who are afflicted with the virus of COVID-19. So there's more to this update, particularly on the new guidelines, and you can Google this in the website of these 2 organizations, Global Sepsis Alliance and Surviving Sepsis campaign. And also, you can also get some data or some articles from the Society of Critical Care Medicine, SCCM. So with this, also in the website of the World Federation of Critical Care. We have their statements pertaining to sepsis, and we are highly engaged in the sepsis campaign. And that even the Philippines Critical Care Nurses Association, we joined the Surviving Sepsis campaign in their September 13th World Sepsis Day. So for April 27, this is a World Sepsis Congress Spotlight, and I hope to see you there. Thank you very much. And again, please don't forget to register for our international conference. This will be co-hosted by 3 organizations: the World Federation of Critical Care, the Southeast Asian Federation of Critical Care, and the Critical Care Nurses Association of the Philippines. And I would like to mention also that Professor Bimala is one of our speakers in this particular international congress. So hope to see you there.
Yes, she's from our department. Okay, thank you, Propel, for your nice presentation and also information that you give us and the invitation. Okay, thank you very much. So to all participants, thank you very much for attend our breakfast at UM. Hope don't miss to join next week UM breakfast. Thank you.